This is the Emergency Medical Minute, sponsored by CarePoint and HCA Health One.
Okay, so I'm going to talk about an interesting case report from a couple of years ago. So this was a 17-year-old girl who was in a car crash and then came POV to a kind of a remote hospital and was starting the initial workup and got a CT scan of her head, and then really right after had a pretty quick decompensation. And as she was decompensating, they were looking at the CT read or the CT imaging, and she had a 1.5 centimeter epidural hematoma, which is a really big epidural, and 7 millimeters of midline shift. And she went from talking to obtunded, blown left pupil, and completely unresponsive. And so this rural facility talked to their neurosurgeon. They intubated her. They were getting ready to transfer the patient, but they knew it was going to be a pretty significant delay of a couple hours to be able to get her epidural evacuated. And because it was such an acute decompensation, they decided they needed to do a Burr Hole in the ER. And this was a kind of a remote place. They didn't even have a Burr Drill. So does anyone know what you could do if you're in a remote ER, you've got an epidural, you really need to get it evacuated, but you don't have a fancy tool? What would you do to try to get the blood out? So use an IO. You use so then they were walking through this with their pediatric neurosurgeon, and they used the blue 25 millimeter, that kind of medium IO drill. And honestly, the most important part of the whole procedure is they together were looking very closely at the CT scan, based on the exact slices where the epidural was, measuring the thickness of the skull to map out exactly where to go. So it was a frontal hematoma. So they could have hit, they had to make sure they weren't going to hit the orbit or the frontal sinuses, had to find the right spot where they'd be able to insert the IO. And so they marked it, prepped it, sterile, and inserted the IO needle kind of right in the middle of the epidural, and then using a syringe withdrew 35 mLs of blood. So we're just withdrawing. They kind of calculated how much blood was in there, what was safe to drain, to suction drain, and they drained 35 mLs. And she almost immediately went from a GCS of 3 to a GCS of 8. So she actually had a huge increase in her mental status, and did have some reaccumulation of blood, but her GCS stayed at about 8. They were able to get her transferred for definitive care, and they extubated her the next day, and she ended up making a complete full neurological recovery. And so, yes, it was a really cool case, and there have been a few case reports. Kind of every once in a while, you'll see case reports of this kind of thing. And there's a really old study that this case report referenced, where they took, I think it was a little over 100 patients, and this was from the 80s. But basically the idea was, if you have a really bad epidural hematoma with lateralizing signs or herniation signs, so a really serious epidural, and if you get definitive treatment of drainage of the epidural within 2 hours, the mortality rate was about 15-17%. But if it's more than 2 hours to get drained, it was like 56%. So it's a huge drop. That 2 hour mark is kind of the magic number of the time frame to get it drained, and certainly the sooner the better. So it's something just to think about. Here we would never really worry about this, but we work at some of the freestanding hospitals. If we're at a freestanding and for some reason it seemed like it was going to be a really hard time getting them transferred, or working out in Delta or one of our more rural sites, and it seems like it's going to be more than 2 hours, it's definitely something that's worth us just thinking about in a repertoire, walking through, looking at the scan with the neurosurgeon, and using an IO. Thankfully, at least for us, our freestanding sites, I'm pretty sure we do have the actual Burr drill, which is, it's always worth for us kind of watching videos and kind of reviewing how to use it. But yeah, so it's something just to remember to have in our repertoires. IOs are good for a lot of things, and just the skull's another bone, and so it can effectively drill through. And but yeah, so it's a case of a really good outcome, and it's pretty cool.
This has been the Emergency Medical Minute. Thank you to our sponsors CarePoint and HCA Health One. Support from them and listeners like you helps us to continue providing free medical education to the masses. If you found this episode valuable, consider supporting our work and check out the link in our show notes.